Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Before we move ahead, and in case you are new here, welcome. And if you haven't subscribed this channel, please do consider subscribing, especially if you want to improve your preparedness for various medical college and competitive examinations. Slipped upper femoral epiphysis, also known as slipped capital femoral epiphysis, is a condition where the head of the femur slips off the neck of the bone at the growth plate or physis. Anatomically, the growth plate or physis connects the proximal femoral epiphysis, that is the femoral head, to the metaphysis, that is the femoral neck. This disease most commonly affects adolescents and pre-adolescents, often during periods of rapid growth and puberty. The diagnosis is easily missed because symptoms are usually mild and the main complaint is a knee pain that is actually referred from the hip. This condition mimics an intracapsular femoral neck fracture and the limb becomes short and lies externally rotated. Slipped upper femoral epiphysis is a rare disease. Its incidence is about 5 per 1 lakh population. Boys are affected 2 times more commonly than girls. 78% of patients with slipped upper femoral epiphysis are adolescents in their rapid growth phase. The peak age of incidence is around the start of puberty, but it may be earlier in girls. The disease occurs more frequently in obese children. The left hip is affected twice as often as the right, and about 25% to 40% of cases are bilateral. In bilateral cases, the second slip usually occurs within 12 to 18 months of the first slip. The etiology of slipped upper femoral epiphysis is not known, but an intrinsic weakness in the growth plate that is subjected to a high axial load is the main mechanism involved. Growth spurt due to hormonal changes reduces the strength of the growth plate as well as its resistance to shear forces. Several risk factors have been suggested that predispose a child to the disease, but none has been proved conclusively to be etiologically related. Main risk factors for the final slippage of the head of the neck are obesity and repetitive minor trauma. Other predisposing conditions are growth spurt, open triradiate cartilage, puberty, genetic factors, Down syndrome, and endocrine disorders such as hypothyroidism, hypopituitarism, and chronic renal disease. The hip in these conditions is at risk and becomes intolerant to normal shear forces. The diagnosis is suspected by the history and physical examination, and it is confirmed on plain radiograph or MRI. Limp due to pain in the groin, often radiating to the medial thigh and knee, is the chief presenting complaint. There is limitation of hip motion, especially internal rotation. In the initial stages, these symptoms may be diagnosed as a sprain and are disregarded by an unwary clinician. Slipped upper femoral epiphysis should be suspected in individuals of 10 to 16 years who complain of vague knee pain which may be referred from the hip. In chronic slips, there may be 1 to 2 cm shortening of the affected extremity, and the lower limb may be in fixed external rotation. The diagnosis is frequently delayed, which may result in more severe deformity and worse long-term results. The diagnosis usually is apparent from anteroposterior and frog leg pelvic radiographs. Confirmation of the diagnosis and the extent of slip may be done by an MRI. Head-neck displacement is often more obvious on a lateral view X-ray. On an anteroposterior pelvic radiograph, in normal conditions, a line known as Kleins line drawn along the upper margin of the femoral neck should transect at least a portion of the femoral head. If it does not do so, a slip may be present. This is known as Tridoven's sign. Subtle signs of slip may be seen first on a frog leg lateral view. If the radiographs are normal and there is a strong suspicion of disease, an MRI should be done to look for a pre-slip and to decide on prophylactic fixation. Slipped capital femoral epiphysis can be classified based on stability, such as stable and unstable, severity, like mild, moderate, or severe, and symptom duration, that is acute, chronic, or acute on chronic. Slip severity is determined on the lateral radiograph in terms of percentage displacement of the epiphysis in relation to the metaphysis. The slip of the upper femoral epiphysis is termed mild if the metaphysis is 33% uncovered, moderate if the degree of displacement or uncovering is between 33 and 66%, or severe where the head is more than 66% displaced from the neck. Yet another method of measuring the severity on a true lateral radiograph is the Southwick slip angle measurement. In this, the degree of epiphyseal displacement or slip angle is determined in relation to the femur diaphysis. It denotes how far the epiphysis has slipped off the metaphysis. The value on the normal side must be subtracted from the value on the abnormal side to get the true value. As per Loder classification, the slip is termed unstable if the patient cannot bear weight on the limb even with crutches. This is the most widely accepted classification of slipped capital femoral epiphysis. An unstable displacement is often moderate or severe, and this situation is very much equivalent to a displaced intracapsular femoral neck fracture. An acute unstable slipped capital femoral epiphysis is an emergency because it bears a considerable risk of avascular necrosis or AVN. It should be reduced within 24 hours of injury and fixed with a screw with or without capsulotomy to stabilize the fracture. The capsulotomy helps reduce the tamponade effect on the blood vessels to the epiphysis, improving its blood supply. Delay leads to increased AVN rates. Chronic stable hips are also treated with a screw or pin fixation. This relieves pain and often improves the range of movement. In the chronic severe slips, a screw placement in a satisfactory position in the epiphysis may not be possible, and there are high chances of significant persistent deformity leading to restriction of joint motion. In such cases, a realignment osteotomy, preferably an intertrochanteric osteotomy, may be considered. Sometimes, due to fixation over a partial or incomplete reduction, the metaphysis of neck impinges on the acetabulum during movement, causing pain and leading to degenerative changes. This situation is called CAM type of femoroacetabular impingement and is abbreviated as FAI. This may require treatment with a head-neck osteoplasty. Slips occurring in children with clear risk factors may be susceptible to failure of a screw fixation, progressive slipping, or contralateral slipping, and in these cases, prophylactic pinning of the normal but at risk hip may be indicated. Percutaneous in situ screw fixation currently is the most effective treatment for both stable and unstable hips, regardless of the severity of the slip. A single cannulated screw system with 7 mm diameter screw and 10 mm threads is currently the implant of choice for fixation. The complications of slipped capital femoral epiphysis are avascular necrosis, chondrolysis, and femoroacetabular impingement. These complications can lead to early osteoarthritis, pain, and stiffness in adulthood.
Thank you so much for watching. Please subscribe and stay tuned for more educational videos.